to be discussing addressing stigma within a community, combating misinformation and stereotypes. And this is the June 29th webinar for the Washington OD2A peer-to-peer webinar series. We're very excited for our conversation today. Thank you for joining. Next slide. So just a reminder that this is a webinar series and this is the second to last session. Coming up next is using learning collaboratives to share knowledge and adopt best practices, and that will be in July. And our typical format is a 25-minute panel presentation followed by facilitated peer discussion. So we're looking forward to that next session. As for today's agenda, we are going to start with some introductions and then move into a panel discussion followed by some breakout sessions, which will have opportunities to discuss in small groups. And then if we have time, we'll have a little bit of opportunity for sharing. Next slide. So let's start with some introductions. My name is Ashley Johnson. I'm a research scientist and practice facilitator, and I am introducing my team here, the 6 building blocks. Dr. Michael Parchman, as well as Dr. Laura Mae Baldwin are joining us, as well as Maria and Sharon, who are also practice facilitators. And just a reminder that the 6 Building Blocks program is an evidence-based quality improvement roadmap that helps guide primary care teams to make systems-based improvements to support effective guideline-driven care for their chronic pain and long-term opioid patients. And if you're interested in learning more, please feel free to reach out to us, and you can also visit our website at improvingopioidcare.org. All right, and so now we'd like to learn a little bit more about you and where you're joining from. So this is always a fun activity for us. So if you could go to the top of your screen, we're going to use the Zoom annotate feature. So if you scroll to the very top, there's something that says view options, and then scroll down to find annotate. And there you'll be able to select a stamp. And if you could please put on the map where you're from. That way we can see the spread of where everyone is joining from. Excellent. We have a lot of people joining from the East Coast as well as some in the Midwest. Excellent. And in the chat, if you also want to list your name and organization and the location, that would also be helpful. Excellent. Yeah, a lot of folks from the East Coast joining. That's great. All right, let's go ahead and move on. Thank you everyone for participating in that exercise. Now I'll hand it over to Dr. Michael Parchman, who will introduce our panel discussion speakers for today. Thank you.
Hello, everyone. My name is Michael Parchman. I am a family physician. I actually work at the Kaiser Permanente of Washington's Health Research Institute here in Seattle, and I'm very, very excited about our panel members and our panel discussion this morning. And let me just first of all say thank you to our panelists, Richard, Tim, and Vicki, who've agreed to join us this morning and just share their experiences and their thoughts about how we address stigma in a community setting. This is something that we have all, I think, struggled with. Anybody who's worked in the area of substance use disorders or opioid use or even opioids for chronic pain and managing patients with chronic pain have faced this issue of addressing stigma. So let me introduce our panelists first, starting with Richard. Richard is an assistant professor in the Department of Internal Medicine and also a physician assistant in the Division of Hospital Medicine at Del Seaton Medical School in Austin, Texas, affiliated with the University of Texas at Austin. He's also director of something called SHOUT, the Support Hospital Opioid Treatment Texas program. This program seeks to increase access to opioid use disorder treatment in hospitals across the state of Texas. And of note, he was the first physician assistant in the country certified to teach in the buprenorphine X waiver curriculum through the American Academy of Addiction Psychiatry. And so he has quite a bit of knowledge and experience, I think, to bring to the discussion today. But I think what we're most interested in today is his work funded by the Texas Targeted Opioid Response Program, a grant in the state of Texas from the Association of American Medical Colleges, which resulted in the development of a toolkit called RESET, Reducing Stigma Education Tools, which is a very robust interactive online learning environment for stigma education. So we're very excited that he is here today. Our next panelist is Tim Candela. Tim is the drug user health coordinator for Washington State Department of Health, and he has over 12 years of experience working with programs serving people who use drugs and individuals who've been impacted by the criminal legal system on this. Things like ranging from direct service experience, such as street outreach and syringe access, to program coordination. In his current role, he works closely with the syringe service programs across the state, allocating resources, providing capacity building assistance and technical assistance and collaboration across agencies. And finally, Vicki Lowe. Vicki, so happy you could join us today. Vicki is a descendant of the Jamestown S'Klallam and Bella Coola First Nations here in Washington State. She began working with the Jamestown Tribe's Health Program and has seen this program through multiple changes in the way healthcare is delivered in our state. But since July of 2015, she's been executive director of the American Indian Health Commission of Washington State, where she's been able to utilize her vast knowledge of how healthcare delivery works in Indian, indigenous tribal settings, and the impact of state and federal regulations on that. But right now, I just want to emphasize that she is very involved in the Jamestown S'Klallam tribal community. And just so you'll know, she's been a part of the Jamestown Canoe family since 2009. And she's been pulling in that tribe's canoe since 2012, and she supports singing, drumming, language weaving classes, and other cultural programs, and was honored as a Volunteer of the Year in 2012 for her work in that area. So thank you, Vicki, for joining us. Richard, let me start with you, if I can, and talk with you a little bit about the RESET program, the program, the interactive program that you developed about stigma education. What led you to develop this online training program about stigma? Can you tell us a little bit of background?
Yeah, absolutely. And thanks so much for inviting me to participate today. So I started working in the substance use disorder space about 5 years ago or so, 4 to 5 years ago. I've been a physician assistant now for about 8 or 9 years, and primarily was doing quality and process improvement work in addition to the hospital medicine practice that I had here in Austin. And the story that I often tell is I used to stigmatize people with substance use disorders. I did not have appropriate training in how to work with and how to treat and how to talk with people with SUD, which unfortunately I now recognize is a major gap in our health training system, which I can talk a little bit about, things that we're working on. But back when I was training, a lot of the exam questions were stigmatizing, the lectures were stigmatizing, my preceptors were stigmatizing. And again, this experience is not unique to me. And so I brought a lot of that kind of baggage with me to my clinical work. And when I was asked to do some quality improvement work around readmissions, I discovered that people who had a history of substance use disorders, in particular intravenous drug use, were at really high risk for hospital readmission. And that's what kind of launched my interest in this work, was recognizing early on that that administratively we were not doing the right thing for people with addiction during hospitalization, and then very quickly realizing that clinically we were not doing all that we could for people with addiction. And so I started a program in our hospital along with an interdisciplinary team to increase access to buprenorphine for people with opioid use disorder during hospitalization. And back then, this is over 4 years ago, I knew nothing. I couldn't even pronounce buprenorphine, let alone start buprenorphine or continue a patient's buprenorphine. And so myself and many of my colleagues really went on this journey to learn how to better take care of people with substance use. And clinically, our work improved, and we were providing better care. We were meeting patients where they were at. We were training our residents and ourselves on, patient first language, and making sure that we were connecting people to care after discharge, and recognizing that hospitalization was a reachable moment, not just to focus on sort of the skin infection, for example, but to really focus on the underlying issue, which was the substance use. And so we've created this really awesome cascade of care in the interim, to the point where we are now funded by the state of Texas to bring that model to other parts of the state. And for those of you who know Texas, some of this work can be quite challenging in some of the southern states. So we're really happy with the progress that we've made, and admit that there's still plenty of opportunity to continue making improvement. This goes to the heart of your question, because when we reflect on that clinical experience that we've had in the last 4 years, and we think about all of the barriers that existed to us doing that work, the barriers that we had to overcome, yes, education is an issue. Yes, reimbursement's an issue. Yes, policy at the state and federal level is an issue. But really, all of those things are rooted in stigma. All of those things are created by humans. Education, our curricula in health professions training is created by humans. Policies made by humans. Reimbursement models are made by humans, and all these humans have stigma. So that's how we landed on, yes, we can teach people how to start buprenorphine in the hospital. That's not unique. There's 101 resources on how to do that, and it's not rocket science. It's super easy, but we're not doing it because of stigma. And so that's how we went about pursuing grant funding to develop our modules.
Great, great. Thank you so much. So I hear that the training program is designed for health professionals. Is that correct?
Yes.
And what is the content? Can you describe it just a little bit? Give just a thumbnail sketch of an overview of the training itself.
Yeah, absolutely. So we received a grant from the Association of American Medical Colleges to develop modules, online learning tools, specifically around stigma of substance use. And we have a lot of experience developing online content at Dow Medical School, specifically around high value healthcare. So not anything to do with substance use disorders per se, but we had the infrastructure and the knowledge to develop not death by PowerPoint educational modules. So that's like the main takeaway, right? It's not like you just sit there and watch somebody's talking head for an hour. So we incorporate different learning theories and different technologies to make it a more robust learning environment. So there are 2 separate modules. Each is designed to take about 45 minutes or so. It includes original videos of people with lived experience talking about how stigmatization affected their ability to receive care. There are interactive activities. For example, there's a history and physical document that we purposely made to be stigmatizing, and it's the participant's role to click through that document and identify the different areas, the different words that are stigmatizing. There are interactive prompts. So as a participant, you're asked different questions. You could type those answers in, and then they are made anonymous and then shared with other users on the platform. And then for physicians, nurses, social workers, and pharmacists, there's free continuing education credit. So these are completely free. They're freely available. They have free CE. And we think they are quite impactful. I saw there's a link that just got dropped in the chat box. There's actually a shorter link, just so you know, if you go to resetstigma.org, so just resetstigma.org, that'll actually redirect you to that very long, complicated URL that is hard to remember.
That's great. Thanks so much. So just one last question. We understand you've begun the process of sort of rolling this training out in clinical settings. Can you describe for us barriers or facilitators that you've encountered to this process of trying to roll this training out?
Yeah, so there are a number of health systems that have adopted these modules as mandatory for orientation purposes. So not everyone in the organization, that's kind of the goal, but at least people who are newly joining the organization. And we've had a lot of discussion about, what does this look like and who needs to do this and why do they need to do this? I think the biggest barrier is time. And people are pulled in a lot of different directions. And for people who are not ingrained in this work like we are, it can sometimes be a bit of a tough sell to say, hey, I think you really need to spend an hour and a half to do this work. And so what I find to be very helpful in those discussions is bringing patient stories to the surface. And so when we started doing our clinical work, we had a really grateful patient who drew a picture for us about being, started on buprenorphine during hospitalization and meeting our team and all of these things. And I bring that picture with me when I go to executives and say, look, and I explain the whole story and explain why doing this work is so important. I think, when you don't do this work every day, you hear about substance use and you hear about its effect on your community and you hear about its effect on your health system and you see the data, but data only says so much. And what's missing from those kind of executive level conversations is the patient story piece. And everybody knows somebody who's been affected by a substance use. It might not be opioids, but it might be another substance use disorder. And so really making this personal for stakeholders has been really effective for us.
Yeah, that's brilliant. It's the old mantra: no data without stories, and no stories without data. If you really want to engage people in change, in making change in healthcare settings. Thank you so much, Rich. I really appreciate your thoughts and your insights on this. And of course, we encourage people who are participating to check out the amazing resource that you've created for us. So I'm going to need to move on. And Tim, I want to first of all, thank you so much. I know you're very busy these days, and I want to thank you for taking time out of your schedule to join us, Tim. You coordinate care in 3 syringe service areas across the state of Washington. Can you just briefly describe your role in terms of your function with those programs and the programs themselves?
Sure. Thank you for having me, Michael, first off. Yeah, so, we currently, through the CDC Overdose Data to Action Grant, do care coordination out of 3 syringe service programs within Washington State. And those vary from urban jurisdictions to rural jurisdictions. My primary role within that is the glorified paper pusher of contract management, and then also the more fun and in-depth stuff of doing technical assistance around what does harm reduction care coordination look like. So that is from practical ways to engage with individuals, from motivational interviewing, for best practices around behavior change, all the way to data collection to show and elucidate the work that programs are doing. And some of the data measures that we collect are outreach attempts. Are they successful or unsuccessful? What type of resources were provided? Were there any incentives provided? So kind of mixing all of that together is what we do. Doing care coordination out of syringe service programs is a newer venture within Washington State. And when we mean care coordination, it's not just picking up the phone and calling another provider and saying, hey, can you take this participant to get on MOUDs or to see a doctor for their diabetes. But it's more outreach-based and harm reduction-based and relational. So that's the primary focus with the 3 programs that we're contracting with in Washington State.
That's great. Thanks. Really appreciate the background. So this is a really interesting phenomenon, the thought of doing this harm reduction and coordinating care through the syringe service programs. I wonder, based on that experience you've had, do you have thoughts about when you encounter stigma, where does it come from and how do you address it in doing your work with these syringe service programs?
That's a really great question. And I think, as Richard pointed out, stigma comes from all directions. You have internalized stigma, which is a reflection of individuals who experience external stigma. And that external stigma can come from the larger community. That external stigma can come from a more micro level with that individual practitioner. So what we theorize and hope to see within the syringe service programs is to kind of reduce those barriers to stigma. So as I'm sure many folks know, the Overdose Data Action Grant is really focused on getting folks connected to MOUDs. So when we first started rolling out this care coordination grant, a lot of our contractors were really focused on that. So I asked them to reflect on that and take a pause and how that could impact folks. Now, anybody who's been working with individuals impacted by substance use disorder knows that historically they've been traumatized and stigmatized by historical treatment settings. So jumping in when you're working with somebody who is experiencing SUD and saying, hey, you know what, let's get you into treatment or MOUDs, you might get some pushback. So I told them to reel that back and really focus on just building a relationship. And so the foundation of that is when you meet with a person doing participant-centered goal plans. So it's not what your goal plan is, a practitioner, it's their goal plan. And unsurprisingly, a lot of it is other things outside of their substance use disorder, ranging from simple things like getting reconnected with their public benefits so they can have some type of financial security, all the way to reconnecting with family members. And what I've learned throughout my experience is when you do your work from a client-centered point of view, you can address the internal stigma because they recognize that you're not pushing all these external forces onto them. And under their own volition, as they start to get their feet and self-confidence, folks may or may not want to access MOUDs, and folks may or may not need to access MOUDs as well to become stabilized. But that's a path that you walk with that individual. So I think that's one way to do it, and especially doing it within the milieu of a syringe service program. It's not a traditional healthcare setting. It's one of the few settings that is working with folks who are currently experiencing substance use disorder, who are also at high risk in rates of overdose and infectious disease transmission because of their active drug use. So providing a low barrier access to care in a non-stigmatized setting really does help. And then in addition to that, the care coordinators will go on appointments with individuals. So let's say they're going on an appointment to get their Hep C treated. What we know is there are a handful of providers that still will stigmatize individuals who are actively using drugs and not wanting to treat their Hep C. So that they'll have fear of going because they don't want to be reminded of that. But when you have an advocate going with you, and you're seeing that somebody is in your corner, that also is another, way to reduce stigma.
Wow, that's fantastic. The idea of this advocate that can go with them and be there for them, kind of at the elbow support. Are there other practical steps that you think you can think of that other programs around the country can take when rolling out a syringe exchange or any other program in a community where you're anticipating the resistance and stigma and fear that we so commonly see?
Yeah, I mean, I think it goes to your saying, Michael, that you provided at the end of Richard's questions around, data and stories. So I think there are pragmatic things you can do, and then there's the emotional side. So the pragmatic thing that you can do is a lot of community engagement, providing the empirical evidence around the effectiveness of syringe service programs. But on the flip side of that, what we learn is simultaneously there's two truths: is things are data driven, and then ultimately nothing is data driven, because if it was, we wouldn't be dealing with the things that we're dealing with. So you really do have to meet the community where they're at as well. So if there is resistance within the community, whether it's around syringe litter or whether it's around enabling drug use, you have to meet folks where they're at, because on the flip side, there are some community members who have been impacted by substance use disorder as well, but they went to the other end of the spectrum and they don't have compassion. They have that tough love perspective. So, you got to do some community level motivational interviewing, ask open-ended questions. And then the community engagement piece can be a lot of work. That is showing up to local business coalition meetings. It's the nightly neighborhood meetings, and being a positive face and not necessarily being resistant and co-signing the stigmatizing ways that communities may feel around folks who use drugs, but meeting them where they're at. And then in addition to that, a really good practical step or public PR for syringe service programs is finding funding opportunities to allow them to also pick up syringe litter within the community. We have a needle exchange program here in Tacoma, Washington that follows all the local community neighborhood Facebook groups where, you hear a lot of negative things, and there will be a photo of one syringe and they follow those and they go and pick it up and they're like, Tacoma Needle Exchange is picking up this syringe. So it's really good PR because a lot of the times folks look at syringe service programs as the reason why that one syringe was out on the street. But if folks also see the syringe service program is out there picking up the syringe litter, they're looked at as the solution and not necessarily the problem. So that's one of the practical ways to address stigma.
Wow. So yeah, that is a lot of work. To follow those community groups and to have engage with them and have a local personal relationship with them. But wow, what an effective model. I can just imagine how important that is in terms of building trust with community members. So thank you. I really, again, appreciate you joining us and taking time to share these thoughts with us. Vicki, I want to turn to you. And first of all, I just want to acknowledge I probably did not do the best job introducing you. And if you want to correct anything that I said about your background and your current role, feel free to do so. I know that you work with the American Indian Health Commission here in Washington State. But can you tell us a little bit more about your background in your community? Anything that I overlooked that you would want the group to know about?
Well, I think it's important to talk about my time at working with the Jamestown Skull and Tribe because I worked in our health program and I helped our tribal members access care. And so I really had a front seat to the opioid epidemic in our community because we went from, and I do remember getting the memo from our pharmacy benefits manager that they were allowing opioid use for non-cancer pain, not in cancer pain, I think that was the wording they used. And it was just such odd wording that it just, I distinctly remember it. And, and as Tim and Richard both said, that having those stories makes a difference in how you look at, I think, addiction issues and knowing the people and watching the changes to them. So that was really important to my background. And then as my work moved from working locally to statewide, the American Indian Health Commission works on behalf of the 29 tribes in the 2 urban Indian health programs in Washington State. And we work at the state level. We have a grant with the Washington State Healthcare Authority who runs our Medicaid program here to work on a tribal opioid response plan for American Indians, Alaska Natives that's coordinated with the state one. And, a couple of things that we who from the tribes in the urban programs noticed when we looked at the state's response plan, it didn't talk about stigma and it didn't talk about trauma. And we felt those were the 2 most important things that should be in your response plans. So we've been working on that. And then just, there's a tribe here in Washington State that had already opened up a medication assisted treatment or MAT clinic up in Anacortes based off of the Johns Hopkins model. So I learned about that model through them, and it's just a wonderful model where it brings all the services needed. And then again, from my experience of working with people, I know the second they leave your office and you refer them to go somewhere else, your chances of success decrease. So having, everything right there is really important. So when the Jamestown tribe decided to, they wanted to operate a MAT clinic here in Cobb County, I thought, who would be against it? And boy, were we wrong. I mean, it's just, it's just surprising how much fear and anger the idea of a MAT clinic here has caused.
Yeah. So yeah, when we talked recently, you told me a little bit about that story, about that situation that developed where stigma really was a barrier to creating a program that would provide access to very needed service in your community. Can you tell us a little bit more about what happened next with that story? And what practical steps, what activities did you and your colleagues take in response to that situation?
Yeah, it was, I mean, pretty shocking because, you know, we work in the health realm and behavioral health, and the tribe really talked with the local behavioral health providers and let them know we were doing this. And everybody was really on board with it, knowing that, you know, the tribe has a reputation for providing really stellar health care. We have a clinic in this community that provides care not only to our tribal members, but to community members, and it sees 17,000 patients. So when they bought the property and the announcement went in the paper that they were buying this property that was zoned for a medical clinic to build this MAT clinic, there was just this instant fear and community backlash that all of a sudden you couldn't go to a city council meeting. People were yelling and upset about all the homeless people that were going to come to swim because of this clinic and all the crime it was going to cause. And it was just, you know, if you just had a check box of stigma statements that could be made, they were all made. They checked all the boxes. So this group actually formed a nonprofit and got IRS 501c4 status. They started out as a Facebook group called Swim Against MAT, but then they found out that you can't discriminate against people who suffer from OUD, that they're a protected class. So they changed their name to Save Our Swim. And what was funny about that is that the lady who is the chair actually doesn't even live in Swim. She lives in another county, but she had political aspirations. So while they were really stirring up the fear and calling it a methadone clinic and talking about these homeless encampments that were going to come here because of this regional methadone clinic, the tribe, you know, they really stuck to staying with getting the application processed for the permits and all that. There was a huge legal fight over that application process, but the rest of us in the community knew that this was important. There's many of us that know people who aren't homeless, but we don't want them to be homeless. Yeah. And we want them to have, you know, their issues addressed. That started meeting and talking about how we could, and we called it changing the narrative, how we could change the narrative in our town about this problem. So, you know, there was attacks on the tribe, attacks on the city staff who were processing the application that hadn't even been submitted. This is like started in May, and the application, May of 2019, the application wasn't submitted till January of 2020. And so all of this time, people, all the anger was just festering. So we really wanted to help educate our community about stigma and about what the truth is about people who suffer from opioid use disorder, and how stigma really affects people's ability to get services. I mean, you know, it's like the biggest issue, the biggest barrier, I would say. So for my part, because of my work with the tribes and with Jamestown, and I was able to do some tribal sovereignty, Indian healthcare 101, because the tribe was being accused of being greedy, and they were going to make all this money off of providing these services to people that, you know, and not understanding how the wraparound services aren't paid for in an encounter rate and all kinds of things. One community member created a website where we could put information that was accurate about MAT and about OUD. And then we took all of the propaganda that the Save Our Swim group had written, and we wrote a MAT newsletter, and it just answered everything that they said that wasn't true. We went to city council. I went with two other ladies here in Swim, and we shared some of the horrible things that this group was saying on their Facebook page during open comments, and asked the city council to sign a proclamation condemning hate speech, discrimination, and racism in our city. And that was on March 9th of 2020. And they didn't do it until we had a petition and got over 2,000 signatures. So finally in June, they signed the petition, or the proclamation, which also directed staff to do some work in our community. So through that work with the city, we created this committee with city staff and community members, and we had some conversations on equity and inclusion. And because of COVID, we had to do them by Zoom, but we held two different conversations, and they were really well received. And people who, you know, when you have stigma, when you have NIMBYism, not in my backyard, you know, it's usually the people who have a lot of resources who can speak up and really, you know, say all these negative things. So we wanted to give a place for the people who hadn't had a voice in what had been going on in our community for the last, you know, year. And so that's what happened with these community conversations.
That's great. That's a great story, Vicki. Thank you for sharing. Just reemphasizes the importance of relationship building and these conversations and creating a safe space for these conversations to happen. So thank you so much. I think we've run out of time for the discussion for the panel. I think we're going to pass the baton back to Ashley, I believe, to take us on our continuing journey in our discussion about stigma. So Ashley, take it away.
Thanks, Michael, and thank you all panelists for a wonderful discussion. Okay, so we are going to move on to the breakout session. Next slide, please. So we're going to divide everyone into small groups, and we will have a facilitator joining you in those sessions. And our goals are to have a productive discussion that will lead to learnings to help with the OD2A work that you're doing in your state. And then we'd also like to share these ideas with the larger group. Next slide. And our discussion questions, as you can see here, we just want to know about some successful strategies that you've used in your community and some of the challenges that you've faced related to stigma in your work. And perhaps if you have questions from others about addressing stigma, this is the time and place to get those questions answered. All right, so with that, I will have Sharon divide us up into these small groups, and we will have about 15 minutes or so in these small groups. So we will see you. All right, and as more folks join us back in the main room, maybe in the last 2 minutes here, if you want to write down in the chat, maybe one good idea or one, I guess, success story that you heard in your group so that we can kind of share that out. And Sharon, if you want to go to the next slide. Michael says, addressing stigma also impacts Department of Public Transport where bus stops are located. It's a great idea. Others in the last minute, as you're coming back to the main room, I know we only have 1 minute, we're short on time. So if you want to just share one idea with the group that you found in your small groups, that would be great, so we can kind of hear some other ideas. And we will be sharing a key learnings document from this session that will include ideas from all of our breakout sessions. Maria says, engaging shatterproof in marketing campaign to reach out to influencers in 3 counties. Great. All right, well, in the last minute here, thank you again for joining our session. We would love to hear your feedback. And in the chat, we did list a short 2-question red cap survey. So please click on that link to tell us what you thought. And also our last webinar will be next month, July 27th at 10 a.m. And it will be about using learning collaboratives to share knowledge and adopt best practices. So we hope to see you there. And thank you again to our panelists and all of our participants for a wonderful session. Have a great rest of your day.
Thanks, everybody.